Welcome to the other side of Lucy Letby. In episode 14, we're going to look at the infamous Lee and Tanswell Paper. There's a clue in the title of this paper that would make one think it wasn't really appropriate in the Letby case, so I'll read you the title: Pulmonary Vascular Air Embolism in the Newborn. Pulmonary, meaning of the lung; vascular, meaning blood vessels of the lung; air, meaning air; embolism, meaning a blockage that has come to a rest. So it says here that pulmonary vascular air embolism is a rare and almost invariably fatal complication of positive pressure ventilation in newborn infants. That's it. So if you don't read any more of the paper and you read that, you come to the conclusion that this paper is about air embolisms caused in babies because of positive pressure ventilation. And it really just sticks to that topic. It says there's been 50 cases described in the world literature to date, and the rarity of the condition and the clustering of some cases, which may be related to specific local factors, do not allow for a meaningful calculation of incidence. So in other words, nobody has a clue how often this happens, according to Lee and Tanswell. And then it goes on with the characteristics of reported cases. So these are characteristic. These are not anything other than a very loose grouping of similarities, like characteristics. So like blue eyes, like brown hair characteristics. Adequate numbers of cases have been reported to develop a profile of those infants susceptible to pulmonary vascular embolism. So it's a profile of babies susceptible. And not necessarily those that are going to get it, not necessarily those that did have it, but those who are susceptible. The reported characteristics of these infants and 3 additional unreported cases of our own are summarized in Table 1. Now let's have a quick look at Table 1. So gestational age in weeks, the range 24 to 40 weeks. It's a hell of a wide characteristic. Birth weight, the range 670 to 3,110 grams. Hell of a range. Age of occurrence, 3 hours to 456 hours. Fractional inspiratory oxygen, so this is the percentage of oxygen in the blood, 250 and 100%, as well as a football pitch. And the peak inspiratory ventilator pressure, that's breathing in, 20 to 90. And the peak expiratory ventilated pressure, 0 to 40. So in terms of characteristics, they're pretty vague and very, very wide. And certainly it wouldn't be wise for any doctor to draw a great deal of conclusions from this. It's basically the gestational age of limit of viability of 23, 24 weeks, right up to 3 weeks post-term. It's any baby who can be born that's ever been on ventilation. That's basically what it means. So if we look at the unreported cases, so that's the Lee and Tanswell cases. One was a boy of 25 weeks gestation who weighed 850 grams and had pulmonary interstitial emphysema. Pulmonary interstitial emphysema is like a collection of air outside of the normal air spaces, the little alveoli, anything that's the anatomical part of the functioning lung. And it's found instead in the connective tissue that joins everything together. All this supportive tissue is called the interstitium, from the Latin word that means inter or between. So the Lee and Tanswell babies, they had this case 2, girl, 27 weeks gestation. She had pulmonary interstitial emphysema and a pneumothorax and arrhythmia. And case 3, a boy of 24 weeks, 640 grams, he had pulmonary interstitial emphysema and an arrhythmia. Now, we have to remember that Lee and Tanswell go on to describe this deep pink rash that they talk about. And that had to come from one of these three cases, because that's the only three babies that they have contributed to this case series study. And the case series studies are very low evidential value in medicine. If we go on, the most common signs included sudden collapse with either pallor or cyanosis. So that's, they went very pale or they went very blue, which was pretty much cover nearly any collapse in medicine, man, woman, or child. Hypertension, low blood pressure, bizarre electrocardiogram irregularities, varied from tachycardia, which is fast, to bradycardia, which is slow, with the latter being more common. A mildewy murmur, where some kind of vague murmur that you might be able to hear, but probably very few people have ever heard. And diminished heart signs are common again in many things in medicine. And then we get to the blanching and migrating areas of cutaneous pallor. So that is areas of the skin that are turning white from place to place. And what that describes is the turning off of the peripheral circulation due to shock. So that's what they say. And this was noted in several cases. In one of our own cases, so that's one of the three above, all of which had interstitial emphysema, or outside the alveoli and between the gas exchange capillaries. We noted bright pink vessels against a generally cyanosed cutaneous background. So what they're saying is that a patch of cyanosed skin, where the blood appears to be blue. I've explained this in other podcasts. It's an optical illusion where the retina creates this appearance of blue blood. And they noticed what they say were bright pink vessels against this blue background. And then they go on to say, this we attributed to direct oxygenation of erythrocytes adjacent to free air in the vascular system, while the tissues continue to be poorly perfused and oxygenated. This kind of doesn't really make sense to me at all. So it's an attribution for starters. There's no proof that this was actually what caused what they observed. So, we got together and we attributed this to that. It doesn't mean anything. It's not proof of anything. So adjacent to free air, that means that the red blood cells were adjacent to free air. Well, red blood cells are contained within blood vessels, so they can't be adjacent to free air. They have to be adjacent to the blood vessel wall and then the oxygen. But that's pretty much the situation that exists in the lung anyway. And then it says, while the tissues, now it doesn't specify which tissues, while the tissues continued to be poorly perfused and oxygenated. But we're just kind of saying here that they are being oxygenated because the oxygen is causing the red blood cells adjacent to the free air to oxygenate. This is kind of pretty poorly thought out, to my way of thinking. It doesn't really make a lot of sense, and yet this is the kind of only bit of this entire paper that was borrowed to be used as evidence against Lucy Letby. And in terms of medical evidence, clinical evidence, physiological evidence, it doesn't make a lot of sense. And it certainly needs a lot more expansion as to what they were actually witnessing, what they were seeing. So returning to the three cases that they report before they wrote this paper: a 25-week gestation, 850 grams, interstitial emphysema and arrhythmia. Pulmonary interstitial emphysema in the second baby with a pneumothorax and arrhythmia. And in the third case, the boy, 24 weeks gestation, pulmonary interstitial emphysema and arrhythmia. So all three of the babies that Lee and Tanswell described, one of which had this pink discoloration, all three of them had arrhythmias. So you could say that the pink discoloration on the vessels that are apparent in the, against this cutaneous background are associated or caused by arrhythmias, because 100% of them have arrhythmias. And they go on to another list here of associated phenomena. So these are associated phenomena. They are really, you could say, they're not related to this, they're just associated with it. So just in the same way that a fever is associated with malaria, it's also associated with a cold. So the associated phenomena in infants who develop pulmonary vascular embolism were Ehrlich syndrome, 94%. So the Ehrlich syndrome is a pneumothorax that are trapped between the lining of the lung, pneumomediastinum, which is in the central part between the two lungs around the heart, and pneumopericardium are around the heart as well. And arrhythmias, 50% of them had arrhythmias. 40% of them had catheter and 35% had circulatory collapse. So 2/3 of them obviously didn't have circulatory collapse, and 11% of them had cutaneous signs. So cutaneous signs are right at the bottom of the list of characteristics that are associated with the phenomenon. You remember that Professor Kinsey said that the cutaneous signs were very impactful. Well, I would say, as someone who did work in pediatrics and preterm neonates, that an Ehrlich syndrome, interstitial adenocarcinoma, pneumothorax, pneumomediastinum, pneumopericardium, and arrhythmia would be a hell of a lot more impactful than seeing a bit of mottling on a baby's skin. I leave the paper reference in the show notes. But the most distinctive sign of pulmonary vascular embolism observed in half of the reported cases is the finding of free air when blood is withdrawn from an umbilical arterial catheter. So what does that tell you? That is a hell of a lot of air. Now we have to go back and remember that the Derry Evans theory of air embolism, as applies to Lucy Letby, was that she administered 3 to 5 mils of air 2 to 3 minutes before. So how does 3 to 5 mils of air compare to air that's pouring out of central venous lines? It doesn't even come close. And this is columns of air. Now, according to the paper, this is columns of air or frothy mixture of blood and air. Very impactful. And these were often obtained. Another related phenomenon observed in 2 reported cases from a different report, and in one of our infants, so we're narrowing it down a little bit now, so one of the 3 that was just mentioned was an inappropriately high arterial oxygen concentration recorded from intra-aortic oxygen electrodes. So there we have an actual piece of data. Inappropriate high arterial oxygen concentration recorded from an intra-aortic oxygen electrode. This was also observed using a transcutaneous oxygen monitor in one case to somebody else's case. And then he goes on to say that a radiograph is diagnostic. So this is a chest x-ray, it's diagnostic. And free air may be seen in both the arterial and the venous systems, as well as in the heart. And they give an x-ray which is literally just full of gas. But we don't know the nature of the gas because no one tested the nature of the gas. In 75% of reported cases, the radiographs were taken before death. And then he makes a really, really important point. Post-mortem radiographs, as used in the Letby case, need to be interpreted with caution, as intravascular air may appear as early as 25 minutes after death, and he gives a wonderful citation for that. Citation number 3, Quisling Pozniak Roloff. Very, very important paper, published in 1974. I actually remember reading this paper myself on the basis of how gas can accumulate in bodies very quickly after death. And the other paper where the gas that is visible on X-rays ante-mortem, so before death, can disappear at the time of post-mortem. So the finding of error on a post-mortem X-ray tells you diddly squid about the existence of an air embolism, and in particular, what was the origin of the error for that embolism, because these guys are talking about respiratory distress syndrome, interstitial emphysema, terms that are not even really used anymore. And the most common cause of air embolism nowadays, or one of the areas where that has shifted now, is the fear of introducing an air embolism because of central venous lines. There's another interesting bit of it. The incidence of pulmonary vascular air embolism. So there's another little bit, just pick 3 bits out of it, you can read it yourself. The incidence of pulmonary vascular air embolism is likely to increase with the improved survival of very low birth weight infants. And the incidence may already be higher than we appreciate because of a lack of recognition of the acute event and a rapid loss of signs after death. So this is the bit that I was telling you about. And again, that paper is Rudd Wigglesworth. And it's oxygen embolism during mechanical ventilation with disappearance of signs after death. So rather than accumulating signs after death, Lee and Tanswell cite a paper that says the sign disappears. Did anyone ever actually read this paper and study it at all? I don't know. And why would it be that if someone comes across this paper, as Dr. Jeran said he did, he came across this paper, why would you start looking for someone injecting air into someone when the first line of the paper tells you that pulmonary vascular air embolism is a rare and almost invariably fatal complication of positive pressure ventilation? There is another important part of this as well. And when we look at the pathogenesis, so the pathogenesis is how does this thing arise? And it says Gregory and Tooley postulated that air embolism occurs as a consequence of air being injected into the pulmonary veins by mechanical ventilation. So that's not into the peripheral circulation, not into a vein that's half a mile away from the lungs. A potential portal of entry into the pulmonary interstitium was shown by Macklin when using gelatin varmine particle techniques. So this is a type of dye marker thing so that you can try and follow the movement of air. And Macklin showed using this technique that microscopic alveolar rupture in pulmonary interstitial emphysema allowed this air to leak out. And further extension of free air into the capillary bed was shown by Lenihan et al. With the demonstration of air embolism in mechanically ventilated dogs with pulmonary interstitial emphysema. So again, you have this constant occurrence of the pulmonary interstitial emphysema, which to me is the most overwhelmingly interesting sign. If you witnessed pulmonary interstitial emphysema on an X-ray during life, and you had a sudden deterioration, maybe you get switched on to air embolism. And he gives the last one, Bowen et al., but he doesn't give a reference to that paper. Bowen et al. Were finally able to demonstrate a direct communication between the airway, the interstitium, and the small vascular channels with barium studies and autopsy of human infants who died from pulmonary vascular embolism. So there we have the chain of movement from the airways, from the alveoli, outside the alveoli, and finally into the vascular channels. It's all very high-level, complicated stuff that you simply cannot pick a pink vessel observation in one baby without describing exactly what the circumstances were. Where did you see the vessel? How long did you see it there? Did it respond to anything? What was your lighting? Who seen it? None of this stuff is given. To really throw a comment in this, it never actually put it in, it wouldn't change the value of the paper. We know now how the pulmonary vascular embolism, according to Lee and Tanswell, arises. It arises because of pressure in the lungs. And the final interesting statement from it in the pathogenesis section, it says that the observed correlation of the timing of pulmonary vascular embolism with gestational age or birth weight, but no relationship with inflation pressure. So it doesn't matter what the inflation pressure is, according to them, suggests that barotrauma, that's the trauma caused by pressure, is inflicted earlier in the more immature lung, and that the development of pulmonary vascular embolism is determined as much by the physical characteristics of the lung being inflated as by the characteristics of the inflation. So in other words, it doesn't matter what the pressure is. They couldn't make that stick even though they were using very high pressures compared to what would be used nowadays. It didn't seem to make any difference. It was the nature of the lung itself. So how appropriate do I think this paper is to end our injecting theoretical amount of air and a theoretical time span into a peripheral vein or into a central line? One of the really interesting things for me as well is the fact that in the index case, per BBA, Dr. Hartness said that there was no change in the electrocardiogram. So the ECG didn't show any change. So there had to be normal cardiac rhythm, normal cardiac function as far as I can measure it. And the reason that it was necessary to say that was so that you could not mix up the possibility that the contentious central line that can migrate anyway may have been in the wrong position, and this may have caused the death of the baby. Nobody can really dispute that. If you put a central line into a baby, one of the risks of doing that is that you may induce an arrhythmia. Whether or not you damage the vessel wall or damage the heart, the mechanics and the concentrated solutions that are going into it could be sufficient to do that in the right circumstances. But Dr. Hartness had to say it, no, everything was okay with the heart. So therefore it must have been something to do with air in the system. But the three cases that Lee and Tanswell quoted there, witnessed and included in this paper, all had arrhythmias. So why was it not discussed that only one of them had this pink vessel, which we don't really know anything about, and I think is really peripheral and indifferent to the purpose of this paper? We didn't say, yeah, but all my babies actually had arrhythmias, and they had interstitial emphysema. So when you looked at an X-ray, you could see her outside the lungs. Circumstances of all of this bear no relation whatever to a nurse injecting her into a pulmonary vein. There's another thing, that these babies were given oxygen, high concentrations of oxygen, during the resuscitation. They may have been on high concentrations of oxygen before the resuscitation, but they were probably given high concentrations of oxygen during the resuscitation. But again, isn't any proper detail about that given. But oxygen therapy itself can affect blood vessel diameter in shock patients, and that happens through a mechanism called reactive oxygen species, where you've got too much oxygen, and hyperoxia or too much oxygen can cause vasoconstriction, which reduces blood flow and may impair tissue perfusion. So if that concentration of oxygen is changing, because it's actually arriving in the area of these pink vessels, and it's arriving in an unpredictable way, that could cause blood vessels to open and close depending on the concentration of the oxygen available to it. And I think that that is a much more likely explanation, this attribution of direct oxygenation, while the tissues remained poorly oxygenated. That kind of contradicts itself, in my opinion. So if oxygen leaks directly into the circulation, it will attach to hemoglobin. But when it attaches to hemoglobin, it will turn the hemoglobin red and not pink. And I'm fed up saying this. So oxygen has to dissolve in the plasma before it binds to the heme group in hemoglobin. And the process is the same, regardless of whether the oxygen enters the bloodstream through the normal respiratory process or it leaks directly into the blood. It will be the same. So again, I'll leave you some references to that. And the other thing is the cardiac output of a preterm neonate is approximately 450 mils a minute. So in 3 minutes, the baby's going to output 1.3 litres of blood. So Lucy Letby puts 3 mils into 1.3 litres. And Dr. J.R. sees discoloration 15 minutes later. I would really love that Dr. J.R. would explain how that all happened. So again, I'll give you references to cardiac output. Now, if we look at venous air embolism, so air getting into the system through a vein, whether it's a peripheral vein, whether it's a central vein, they do kind of refer to the same condition, provided that certain things hold true. Venous air embolism and pulmonary air embolism refer to the same thing, in which air enters the systemic veins, travels to the right side of the heart, and then into the pulmonary arteries. So that's the kind of chain, whether it goes into the central line or whether it goes in through the normal way. And this can obstruct blood flow in the lungs, and it can lead to serious complications. And the terms are used interchangeably, but they're not really the same thing. So venous air embolism is when air enters the venous system, typically through procedures like catheterization, and the air travels to the right side of the heart and then to the pulmonary circulation, potentially causing pulmonary artery hypertension. That's a rise in the pressure of the pulmonary artery and right heart strain. And this is where you will get that arrhythmia from. If the right heart pressure of the right side of the heart goes up, that's going to cause electrical problems with the heart. And pulmonary air embolism specifically refers to air embolism that reach and obstruct the pulmonary arteries directly from the lung. Again, they can cause similar effects, but their etiology and their origin is all slightly different. And again, I will give you some references to that. And then when we look at, again, the modeling, the sympathetic nervous system, the autonomic nervous system, has a really critical role in regulating the vascular tone. So that's how much the arteries and veins are constricted. For a lot of things, vasoactive substances, conditions like sepsis, for instance, can lead to the release of inflammatory mediators, and that causes vasodilatation, increased vascular permeability, and oxygen and pulmonary air embolism, believe it or not, also causes inflammation. So the air in the system, the free air in the system, causes inflammation. So there's no reason why it could not cause vasoactive substances, or that the sepsis couldn't cause vasoactive substances, and that these could lead to changes in the blood vessels that would be visible to the eye as pink vessels. Low levels of stress, steroids in the body, all these things can cause that, But regional endothelial dysfunction, that's the inside of the blood vessels, they don't function right when the patient is in shock. And that leads to impaired vasodilation and reduced blood flow to the skin. Blanching and migrating area of cutaneous pallor can be caused by shock due to reduced blood flow and vasoconstriction. That is just the way it is. Much, much better explanation. If you ever see a baby blanching, that's not a good sign. Respiratory distress, tachycardia, tachypnea, all the things that baby A had were pointing to a problem long before it happened. Again, you cannot say a baby that's persistently breathing fast is a stable baby. And you can't say that it's okay that the rate of the tachypnea was stable. But that's just nonsense. Finally, we'll just have a little look at another paper from the archives of disease in childhood, which is an interesting paper as well. And it was published 3 years before the Lee and Tanswell paper. And it's called Pulmonary Air Leak in Extremely Low Birth Weight Infants. So just a summary of it, the incidence of pulmonary air leak in 230 infants with a birth weight between 500 and 999 grams who were ventilated was 41%. Pulmonary interstitial emphysema occurred in 35, pneumothorax in 20%, pneumomediastinum in 3%, and pneumopericardium in 2%. The survival rates in those with or without pulmonary air leak were not significantly different in the first 4 years of the study period.
We'll just make reference now to Professor Michael Hall, the defence witness that was never called. And Michael wrote a letter to the British Medical Journal where he makes various points. The only point I would make is that had the judges read about sudden unexpected postnatal collapse, they would realise that skin discoloration has got nothing to do with the sudden death of infants. The sudden death of infants is something about which we know very little and we are learning all the time. But to associate anything in this Lee and Tanswell paper to what happened in the Countess of Chester Hospital doesn't make any sense from a medical perspective, from a factual or scientific perspective, because we're comparing apples with oranges, which is not a common pursuit in science. So I'll just leave you with a little bit of Professor Hall's letter, and I'll leave a reference to the letter.
The phrase skin discoloration appeared 48 times in the 31,000-word document. The names Lee and Tanswell appeared 25 times. Those who are familiar with the details of the trial will be aware that some of the babies who were subject to the trial had skin discoloration, and that a major component of the prosecution case was that skin discoloration was caused by Lucy Letby injection of air into the baby's veins, leading to air embolism. What Professor Hall says that the judges appear to have agreed with 2 of the prosecution expert witnesses that any form of skin discoloration may be caused by the injection of air, provided that skin discoloration is not the only clinical sign. The judges did not list the other signs, but sudden unexpected collapse seems to be one of them. We'll just get to the end of this podcast now, but the bottom line in all of this is that the Lee and Tanswell paper is a very dated, very old paper that talks about situations where people were using very high levels of oxygen, very high pressure levels, with positive end expiratory and positive inspiratory pressures, when the norm nowadays and in the norm in the Letby cases was to use positive pressure ventilation, where the pressure is positive all the time. And the purpose of that is to keep the lungs open and allow the baby to breathe easier. There's no realistic comparison between the Tanswell paper and what actually happened in that neonatal unit. And it's bizarre to me that someone who would read a paper that refers to a complication of mechanical ventilation would fail to consider mechanical ventilation as the cause of whatever it was that they said they witnessed. I don't understand that, and I would love to have a debate about that. See you in the next episode, and bring it back on track with the case at BBC.